Welcome, everybody. My name is Brian Edlow. I'm a member of the Neurocritical Care faculty at Mass General Hospital and the Vice Chair of Research at Mass General Brigham Neurology. It is an honor to host this session with this multidisciplinary panel of world experts and visionaries who are developing advanced neurotechnologies, such as brain-computer interfaces, to restore communication for individuals with severe neurological disorders. Communication is fundamental to the human experience. By expressing ourselves through speech, written expression, and gesture, we are able to connect with family and friends. And for patients with severe neurological disorders, this self-expression is essential for communicating basic needs such as pain and hunger. Today, we're going to be talking about two patient populations. First, individuals with locked-in syndrome. These are people with ALS, brainstem strokes, or spinal cord injuries who have retained higher-level cognitive function, language, attention, complex reasoning, emotion, love. These are all intact. But because they are paralyzed and unable to express themselves, they are locked in. I'm happy to hear the pager going off. We were joking that makes our panel more authentic because we have an ICU doctor who's on call at this very moment. The second patient population we'll be talking about is individuals with covert consciousness, also known as cognitive motor dissociation. These are people who have had a severe brain injury, such as from a trauma, a stroke, or from a hemorrhage, and their level of cognitive function is not normal, but is still greater than what we can see on the bedside exam. Recent studies have shown that 25% of these individuals who cannot follow a simple command at the bedside, they won't give you a thumbs up or wiggle their toes to command, a quarter of them are actually hearing and understanding us as assessed with task-based functional MRI or EEG. And for both of these patients' populations, there is an urgent clinical need, an ethical imperative to establish communication channels and restore self-expression. So let's jump into it. The first question is for you, Daniela. In January of this year, you wrote a poignant op-ed in the New York Times talking about your experience caring for this patient population in long-term care facilities. Take us to the bedside. What is it like to care for these patients and to communicate with their loved ones about the patient's current level of consciousness?
Sure. So I'm a medical ICU doctor, and I also do some work at a long-term care hospital. And there we see patients who have suffered brain injuries. And my job really is to kind of like look at their trach tube and manage their ventilator and these sorts of things. And so, you know, you come into the room and these are patients who, just by definition of being a long-term care hospital, are generally at least a sort of month out and often more from their injury. And the family has, you know, the sort of vibe of a kind of beleaguered family that has been through a huge amount. And I feel like, you know, we walk into the room, you know, manage the things that are to be managed. Sometimes the television's on, sometimes it's not. And when you communicate with the family, you're really just communicating in the absence of any kind of knowledge. Often by being people who have made the decision to move forward to be in a long-term hospital, they're people who have held on to some hope. And in my own head, I have no idea often if the hope is realistic. Are we protracting suffering with some goal that is not to be achievable? Or are these hopes realistic? And how do I even parse that out? And how do I think of this person in front of me? Is this the memory of the person that was? What remains? And how do you communicate with a family about somebody who maybe was there, maybe still is there? They believe the person is there. What does it mean for the person to be there anyway? And so there's a ton of uncertainty. And in a long-term care setting, really an inability to even begin to ask questions that with current technology could potentially begin to be answered.
Thank you, Danielle. And some of the themes that emerge from your description of these experiences are uncertainty about personhood, what makes us who we are, about autonomy. Is this person a candidate for some type of assistive communication device? And these are themes we'll come back to throughout today's session. So the next question is for you, Lee. As the director of the Center for Neurotechnology and Neurorecovery and the principal investigator of the BrainGate study, you have been a pioneer in this field for years, taking what many of us considered to be science fiction and bringing it into scientific reality, allowing people who cannot express themselves through ordinary means that we would usually consider speech, expression, gesture, or writing, and allowing them to control a robotic arm, or speech translated through a computer by translating thought into handwriting or computer-generated voices. And so the question for you is, can you describe the landscape to us over the last 10 years? What have the key milestones been for your BrainGate study and for the field? Where are we now, and how close are we to being able to restore communication for these patients?
Thanks, Brian. The last 10 years have been amazing. They've been amazing in part because if I go back another 10 years, if I go back 20 years to begin with, this was an academic endeavor. Was it going to be possible to allow somebody who's awake and alert but is unable to speak, is unable to move, to once again be able to communicate fluently with their loved ones, with their healthcare providers, with their friends and family? And right about 10 years ago, academia, federally funded research, had basically de-risked this entire field for industry, allowing for the first time small startup companies to take the best of that academic research, not only from our own BrainGate endeavors, but from others around the country, and to really think about how does this become a medical product? How does it become an implantable brain-computer interface that can be hardened to the point that it can actually be submitted to FDA for what would eventually become a first-in-human, an early feasibility trial, and then subsequently a pivotal clinical trial. And now there are half a dozen companies that are actively engaged in either early clinical trials of implanted BCIs for the restoration of communication, for the restoration of mobility, or will soon be. And that, to me, again, at the bedside, I too, when Danielle's pager went off, I too was thinking, can I borrow that from you so you can answer the question? We'll do our best.
I'm signing it out right now.
Okay, good. We both, as do you, Brian, when we're in the intensive care unit, and there is somebody who we want to help, what we want to say when that person is there, and we know that there's a technology that could restore communication and mobility, we want to be able to provide it, and I think that this field is getting closer to achieving that.
Very exciting to hearing those optimistic thoughts, and in the second half of this discussion, we'll get more to future thinking. What do we expect on the horizon over the next 5 to 10 years? So I'd like to transition to you now, Bruce. As the director of the Martino Center for Biomedical Imaging, you have been at the forefront of countless advances. The discovery of functional MRI, you were the senior author on the first fMRI paper, 1992 PNAS, the leader of the Human Connectome Project, mapping the wiring diagram, the structural connectome of the human brain. These are all innovations that have come out of the Martino Center. How have these types of advances in functional and structural imaging built a foundation for identifying individuals who could benefit from these types of devices, and how can they help to move this field forward?
Yeah, excellent. Thanks, and thanks very much for the opportunity to be here. It's interesting, when we first started doing our fMRI experiments, there was real controversy in the field. There was kind of a traditional approach with PET imaging, and a lot of skepticism on the part of the people that had spent a decade using that tool as to the validity of our tool. And of course, we had shown basic sensory activations, visual system, motor system, but people were really looking for us to show something beyond that. And so actually, we brought a group out from WashU. They were pioneers in using the PET technology, and their question was, could we see something in higher order cognition? And sure enough, of course, it was language. It was the verb generation task. And so our very first kind of higher order cognitive demonstration, of course, it was successful, and folks like Randy Buckner basically moved from St. Louis back to Boston to carry on that work, was in language. And very quickly, our first clinical application of functional imaging outside of motor system mapping pre-surgically was in language lateralization and localization, again, prior to surgery. So both in terms of the demonstration of the tool as an ability to see cognition, higher order cognition in the brain, as well as early clinical applications, language, that kind of quintessential human function was really the target. Over the last, now it's been 30 years, the technology has improved really significantly. We now have the ability, of course, to image the entire brain and do so with high temporal resolution and high spatial resolution, so we're getting just a lot more data out. We're getting much more sensitivity as our magnetic fields have grown and the underlying technology for the detection of the signal. And most important, the development of AI tools to analyze that data have, of course, exploded over the last 5 years. And so Just over the last 3 or 4 years, there's been really an explosion of the application of all of these tools together to be able to assess language more than just saying, here's a spot in the brain which is involved in language, but actually being able to decode language, spoken or imagined. There was a brilliant paper by Alexander Huth recently, which showed not only the ability to generate language, but actually that multiple networks in the brain could each independently subserve the ability to interpret full language, including at the level of words and entire phrases. And this, of course, has great implications, something that Lee was talking about before. The location of lesions may not have to be in critical brain areas that we know from lesion studies, the Broca and Wernicke's area. In fact, multiple areas in the brain. In fact, functional imaging studies have shown if you have enough sensitivity, almost the entire brain lights up. And so we may have more flexibility than we know. We've learned that. The most recent AI tools have now shown without kind of pre-constructed candidate sentences or whatever, we're now able to use these autoregressive generation techniques to be able to generate language, whole entire phrases. So that technology has really improved significantly. And we're actually now kind of reversing it, learning from our AI tools about human language itself, because we've now seen, for example, that when you build LLMs around kind of short-term integration of context, it does less well than if you kind of combine short and longer-term, longer contextual cues into language. So we're learning about the fundamentals of human language using these a combination of functional imaging tools and AI models, as well as, of course, then using that knowledge to go ahead and allow us to generate what people are thinking about, what they're trying to articulate to us.
Thank you, Bruce. Really appreciate you sharing your thoughts and perspectives and several themes that I want to come back to, including what do we do when patients have lesions, when there is a brain injury? How do we know who is physiologically receptive to a brain-computer interface? And if so, where do we place these devices? Noah, first I want to thank you. You traveled by far the furthest to be here, so thank you for joining us and traveling across the country to be here. We really appreciate it. And you see this issue through a different lens, coming from industry, multiple different companies that you've been affiliated with now, Paradromics, at the cutting edge of this field, and would be curious to hear your thoughts on key developments over the last 5 to 10 years as far as industry-academia partnerships, and in particular for Paradromics, what are some of the key developments over the last 3 years since you've been there that you'd like to highlight for the audience?
Sure. So Paradromics is a company based in Austin, Texas, and we are building a brain-computer interface platform for the patient populations we've spoken about, specifically for speech and motor impairments. Our strategy and our workflow has involved working with experts, some who are on our panel here, who've done this before, who've demonstrated in the academic space, starting with sort of initial proof of principle and getting into more advanced studies, expanding the capabilities of existing research platforms. The reason our company got started was this vision of a future where we can go beyond research products and develop a medical device that can eventually be available for doctors to prescribe to their patients for speech disorders or decoding speech, providing the restoration of motor outputs or the decoding an intended motion like speech and providing the functional output from there. The work that's been done in academia is tremendous. And my role coming from regulatory and clinical research and being involved in medical device companies for 20 plus years, it's a similar scenario that I've seen in other areas where this tremendous research has been done at the academic level and things are moving in a direction where proof of principle, safety, identification of the mechanism of action, how do these devices work, what do we need to do to make them better, where are the most optimal or most obvious cases for patient populations that are dramatically underserved. And then pursuing that from a company perspective, where again our motivation is getting to that world where devices are available for use, not just in the US, but internationally. And when we have developed our clinical research program, working with Lee and other folks who've been involved in the BrainGate program as well as outside of that, what we're finding is that it may be a fairly obvious statement, but it's very helpful when you work with the most experienced folks who've done the same thing or similar things with different technology in the past, to be able to build a team of experts who legitimately want to collaborate on this project, this clinical study headed in a direction that we're all in favor of. And in this early phase, emphasis on safety, but also on the expanded capabilities of a new system, including the platform system that Paradromics is building, which is a fully implantable system intended for permanent implantation long-term, and leveraging other experiences such as DBS and surgical technique involving the placement of electrodes and leads and IPG-style devices. So all that's to say, working with the experts who've done this before, who've done similar things, and it's not so much a baton handoff, but more like a new freeway has been opened up and the toll road to this new destination is now available, and we're driving full speed along that road.
Thank you, Noah. So let's start to transition now to the present moment, the future landscape. We have a patient in front of us whose family is asking for access to one of these devices. We've talked about the clinical motivation for restoring communication, the ethical imperatives, some of the imaging developments that have kind of built the foundation, and electrophysiological advances that have made this technology possible. But if we have a patient in front of us now, let's take, for example, Lee. You receive calls from all around the country, all around the world, for individuals, families, where their loved one is locked in, whether from ALS, brainstem stroke, spinal cord injury, and they want to give their loved one a chance to express themselves. The first question is for Daniela. How do we begin to communicate with these families to explain to them what the opportunities might be for their loved ones to express themselves? We think about risk and benefit, broadly speaking. How do we communicate with the public to get people to understand how and why these techniques might be beneficial to our society?
I mean, these are great questions, and I would just I think back up even one step farther. And so you're getting calls from people who clearly know about something because they know to call you, right? I'm seeing people in a long-term care hospital who are like, and they're in a long-term care hospital in Cambridge, which is like Brigham and MGH affiliated, and still, I've never gotten de novo like a question. I mean, maybe they ask their neurologist, but I think that there are a few families there who know to wonder. And so I think that even backing up, there's a question of like, do we do harm, or are, when, how to communicate this to a public that doesn't know about this, and how do we do that in a way that's responsible? I mean, the article that you had mentioned, I really debated about even writing about it, because was that irresponsible? Was I a purveyor of false hope? And I think that that's a question. So in my mind, there's a starting question beyond like, how do I communicate this? Do I communicate it? And then, of course, what is the inherent paternalism in my even asking that question of myself? Who am I to hold the information or to dole it out? At the same time, when I don't even understand the sort of basics of who is a candidate for this, is it right? Is it the right thing to talk about this more broadly? So I'd love to know from you actually, and all of you, like how should the sort of average clinician who's not a neurointensivist think about this in response to your question?
Do you want to take that, Lee?
Sure. Daniela, you are not an average clinician. Let's just start there. You're well.
Okay, how should a clinician who's not neurointensivist? Yeah. There's no false modesty there.
Fair enough. So you've identified an incredibly important challenge for this field. If we pivot for just a moment, let's think about movement disorders and Parkinson's disease, and the availability of deep brain stimulators. These are technologies that they've been around for about roughly 20 years. They work, and at best, there is maybe about 15% of the people who could potentially benefit with Parkinson's disease or other movement disorders from a deep brain stimulator actually get one. And this is a field where the clinical care is actually somewhat clear. PCP and patient discuss early some difficulties in movements, maybe some tremor. In an initial evaluation, they find their way to a neurologist. There are medications that are provided, there are dopaminergic agonists and other medications that are provided to reduce the symptoms of Parkinson's. And then not too far after that, what should happen is that for the appropriate patients, a deep brain stimulator is recommended. That patient sees a neurosurgeon, multidisciplinary group of clinicians, and the right patient receives the right technology. When we're talking, just as you said, about these brain-computer interfaces, these technologies that could restore fluent communication at the speed of speech, control over one's tablet computer, there is much less information that is known out there to the clinical community. There is no tried and true clinical pathway yet for somebody who is in a chronic care facility, who's in a nursing home, to be identified as, oh wait, you might qualify for one of these technologies. And so that needs to be built. The physicians and other clinicians who are working in these institutions providing extraordinary care need to be educated. And that's our job as a field, to provide that education of, hey, there's this other technology, it might work. How do we refer somebody for an evaluation? And at MGB, we've launched a BCI clinic, a brain-computer interface clinic that's being led by Dan Rubin. He's seeing many patients now who, as Brian, as you were saying, who used to call, or their families used to call or email me. We now have a location where patients can be evaluated, where the technologies that are available can be discussed and recommended, where the technologies that may become available, either from a clinical trial standpoint or from a future device approval standpoint, can be discussed. And that's how we begin to build this field. But so we have one kind of center of excellence, center of knowledge at MGB, where we're beginning to provide that expertise now to patients around the world. But that is just the beginning. And maybe I will just add to that, as to what Bruce was describing before. One of the questions that's going to come up is, Daniela, you see a patient in the clinic or in the long-term care facility, you identify them as potentially benefiting from BCI. Then our job, together with Noah and others, is to figure out where exactly should that device be placed. These are small recording devices, incredibly powerful, that are going to be placed somewhere in the brain. And it's really because of the expertise at the Martino Center and the development of resting state imaging and learning about these incredible networks involved in speech and language that we can identify different places in the brain where recording, kind of listening in on that connectivity, on that neural activity, is going to restore communication, is going to restore mobility.
So equity issues. Are families who are more medically savvy and fluent getting greater access? There's issues of education, us experts educating fellow clinicians about the potential benefits of these devices. And I think we would all agree that to truly move this forward, we need pivotal clinical trials. And Noah, I'd like to bring this back to you. So as we think about the clinical trial landscape, let's get into the details. How do you think about inclusion-exclusion criteria? How do you think about device placement that Lee alluded to? We're mostly focusing thus far on intracranial brain-computer interfaces. Is there a role for less invasive extracranial scalp-based devices? Help us understand how you think through the clinical trial landscape.
Sure. I think the first thing to acknowledge is, where are we really in today's world in this research? And while Neuralink grabs a lot of headlines, Synchron is out there working the BCI space, we're still early. Just the totality of clinical research participants across BrainGate, other studies, and now industry-sponsored, it's still in this beginning phase. So that translates to inclusion-exclusion criteria. Who are we looking for? Paradromic strategy was to start again with, what do we know from current data? What can we read from and learn from these studies that has been successful? We also have been collaborating heavily with FDA, and I'd love to give a shout out to our regulatory agency for being so forthcoming with information, guidance, details, and collaborating in the implantable BCI collaborative community effort to help companies like Paradromics and others understand how to do this, how to think about this. And the best way to think about it is, what does the data say is the strongest chance of benefit with the lowest risk? And that's where these studies are getting started. From there, as we think forward towards future studies, even pivotal study landscape, that's where things will get a little broader. But in the beginning, the inclusion criteria is less than it will be in the future. And that's predicated on the awareness that we've demonstrated certain things may work for certain individuals. In terms of placement, placement of the device, placement of our electrode array in the brain, that comes down to, I'd say, existing knowledge of neuroanatomy, neurophysiology, and the data that exists demonstrating where these functional areas are located. And in conjunction with that, leveraging advanced imaging like fMRI to preoperatively work up a candidate to have the highest confidence in a successful implant of an implant in this target region, accommodating and targeting not just functionality, but also the anatomical structures like vessels, and avoiding some of the surface topography to have an optimal implant location.
So following up on that last point, Noah, and bringing this to you, Bruce, you talked about some of the advances at the Martino Center and elsewhere over the last decade or two, and we hear the buzzwords like precision medicine or personalized medicine, brain fingerprinting. How close are we to using these advanced imaging techniques, structural or functional, to create personalized maps that could select patients for these clinical trials and that could guide the placement of these interventions?
Yeah, it's a super question, and one that I was hoping to put, listening to Daniela talk about her chronic patients. Presumably, some patients really are in a position where they could benefit if they could communicate, and others, for other reasons around them, may less so. So the question is, to what degree do the non-invasive techniques, can they provide both an anatomical, functional roadmap for where to place things, and even have a determination of whether their brains are really kind of ready to be able to respond in that way to get enough benefit to warrant, the associated costs and potential, modest risks associated with such procedures. And I think the short answer is we can do pretty well, and I certainly anticipate doing better still. The Human Connectome Project, as you say, we now have an increasingly good awareness of the connectivity patterns of the brain. The functional studies now allow us to see at high temporal resolution with high sensitivity the entirety of the brain. As we're learning from some of the cognitive neuroscience, we have a number of potential targets, beyond the kind of traditional ones. And then the additional constraint of the anatomical constraints, gyral sulcal folding patterns, which do not necessarily directly predict the functional outcomes, so you really do need to measure them in individual patients. Add on top of that the limitations of vascular anatomy, et cetera. It is a complex kind of dance of knowing the potential functional areas, how they lay out in the topography of the brain and the interface of the devices, safe areas to apply things, and then whether the patients really, their brains are kind of capable of providing that kind of information. This is where I think the non-invasive tools probably will show the greatest use. People aren't going to live inside of fMRI systems, but maybe living inside it for a short period of time before they go to these next steps would make sense.
So we've talked about the rapid pace of progress and the reason to be hopeful for the future, but there are also barriers to overcome. This is incredibly challenging work, and again, a tip of the hat to those of you who are pushing this forward. So I'd like to go down the line now and ask each of you, what do you see as the greatest barrier that the field faces, whether it's from an academic or an industry standpoint, and what do we as a group need to do to overcome it? So I'll start with you, Lee.
Probably the biggest barrier, biggest challenge, we try to use a neutral word to get there, but barrier, is these technologies. If we think about somebody who's had a brainstem stroke or has ALS and has lost the ability to speak, and there's an implanted brain-computer interface that restores their ability to communicate at 60 words per minute. And there are academic demonstrations from our own BrainGate team and others of somebody who cannot be understood by anybody except for perhaps their spouse and one care partner, but who now, by attempting to speak, that attempt can be decoded in real time. Those words appear on a screen. Those words are spoken aloud from computer-generated speech in his own voice. Those 60 words per minute that are being communicated, being used for work, being used to communicate with one's family, it's clearly helpful. That is a good, and everybody who sees that would acknowledge, wow, that's something that is going to help that individual, could likely help many others. But 60 words per minute, for that matter, 30 words per minute or 10 words per minute, is not necessarily a validated outcomes measure for an implanted medical device that has ever been used to approve a device for market by FDA. And even if it was, let's say that that was true, that it could be approved based on just that output, it's not necessarily a health outcome that would resonate under the code by which CMS, that is Center for Medicare and Medicaid, can reimburse that technology. Now, again, at a first pass, this is good. It should be approved, assuming that it's safe and effective, and it should be reimbursed. But we may not actually yet have the structure to be able to get there. No one mentioned the Implantable Brain-Computer Interface Collaborative Community. Quick shout out to ibci-cc.org. That organization is a very formally by MGB chartered pre-competitive space that's now allowing companies that would otherwise be competing and liaisons from federal agencies, and including FDA, and academics and people with lived experience of paralysis and their care partners and ethicists and others to have very open discussions about these genuine challenges in the field where here's a technology, it needs to be on a path where FDA can even approve the design of a pivotal clinical trial, which, as people in this room recognize, means there needs to be some outcome measure that is agreed upon ahead of time by which success can be determined. And so that is an ongoing discussion. It's one of many in this field when we're basically developing a new class of devices that can restore functions that previously have not been restored, and we want to make sure that there's a smooth, effective, and clear path so that as each company develops their device and develops their trial, that they know how they can get across the finish line.
Thank you, Daniela.
That's really interesting. I think two sort of, themes I'm thinking about in terms of challenges or barriers, are not specific to this technology, but one is just sort of caregiving overall. And I was interested, working on something else, and I was interested to learn that of everybody with ALS, it's like an exceedingly slim percentage, less than 10%, who, and you guys probably know this better than I do, but who choose to move forward with tracheostomy and mechanical ventilation. And then in sort of looking at studies of why people say that, a lot of it has to do with the burden on caregivers and what that means for where they live and things like this. And so, when we're talking about these technologies, it's not sort of, the patient in a vacuum. And there isn't, our health system is not set up so that if you don't have a caregiver, you're in a long-term care facility. And what does that mean for your caregiver if you're not? And so I think that overall system is a challenge when we talk about, it improves the quality of life, but when we talk about making decisions about continuing life-sustaining technology with this as a hope at the end, I think that overall system of care and sort of how that falls down is a challenge. And I guess related to that is, the sort of ableism that's inherent in the medical system and in our medical decision-making. And really, talking about sort of people with the lived experience of paralysis, like really thinking about, at the outset, I think there's a lot of conversations about they would never want to live this way. And even the idea of enabling speech in the absence of motor control, as we understand motor control, the assumption that would not be a life worth living. And I think for some that is true, for some it is likely not, and sort of probing that and probing those of us who make those, who sort of have the conversations that kind of embed this framework into it. And I think you guys probably from the neuro standpoint, like you sort of maybe err on a side that makes other doctors sort of wonder, are you giving too rosy a view of what this would be like? But outside of the neuro intensive care unit, I think we have conversations that are very negative about what these sorts of states could look like, and I think that sort of those two things together are challenges.
Well said, and thank you, Daniela. Bruce, I'll pass it to you as far as challenges or barriers that we face.
Sure. I think we're pretty close to having the non-invasive kind of pre-surgical mapping tools that we need. And they're certainly going to improve, especially on the data analytics side, lots of improvement there. Every month there's another advance in our ability to generate speech based on these data. But that problem I feel like we mostly have in hand. I think the more challenging one, looking a little further down the road, are kind of other non-invasive ways that could be much more portable than putting somebody in an fMRI scanner. As Lee well knows, I mean, there's been significant progress in using EEG. There was a recent study by Jean-Remy King, which actually showed that MEG, somewhat surprising to them as well as to me, did substantially better than EEG. Now, of course, MEG is another one of those technologies today that, like fMRI, is not really portable, but there is a new generation of so-called optically pumped magnetometers. They don't require the liquid helium bath that the squid detectors do. That technology is advancing rapidly, and so perhaps the combination of EEG and MEG or optical methods, which are also significantly improving. What we've learned from the fMRI is that there are these distributed networks. It's not just a single region that we have to target, but that's also an advantage because it means we can get signals from across the brain to try to tease out what the brain is trying to communicate to us. I would love to see the opportunity to begin to bring some of these techniques much closer to the bedside and chronic disease settings, whether we can get to the point where people can walk around and essentially talk with these things. That's a further step, but I think that there's good steps to take, and I think we'll make progress on these non-invasive measures that so far don't perform as well as the invasive methods, but are getting better and I think have the potential to get significantly better still.
Thank you, Bruce. And Noah?
So from my perspective, working in a company dealing with clinical research and the regulatory process to get a medical device approved, the challenge is, it is the process. The process is the challenge. And that starts with the technological challenges, engineering a device for long-term implant, functional, working through those challenges to get to a product or productizing what is available for clinical research and then translating that into the clinic. The other important aspect of it is knowledge and education. Expanding the, I'd say, broad public knowledge base, but also within the field, expanding and deepening the experience, sharing the information that we learn as we go, literally study participant by study participant. There will be a regulatory challenge of working through submissions for clinical studies, and then eventually for a product approval, and product approvals or indication expansion beyond that. I think all this is to say that the biggest challenge is time. The time it takes to work through this, finding the right individuals to partner with, whether they be employees of the company, clinical research centers, FDA and other regulatory agencies, and really focusing on the people that we're working with, including study participants, in order to drive down this freeway towards this innovative medical device space that we're working towards. I think also being willing to look in the rearview mirror and think about where we came from, what can we learn, what can we apply going forward so that we don't encounter the same challenge again and again and again, but rather learn from where we were and be open to acknowledging things that didn't work in order to optimize what does work.
Thank you, Noah. As you can tell, our panel is very passionate about these issues and we could discuss them for hours. I'm mindful of the time. We've got about 2 minutes left, and so let's transition to concluding remarks. I'd like each of you to comment on what you expect we will be seeing over the next 10 years. In 2035, what will the technology look like and how widespread will it be accessible? And maybe we can go down the line from Noah down to Lee. We'll give you the last word, Lee.
Sure. Medical device, world medical innovation, brain-computer interface is fairly innovative. I like to, again, using that rear view mirror, look back at other spaces that have come from nothing. There was a time when maybe even corrective lenses was something that people didn't know about, or orthopedic total joints. Interventional cardiology, driving a catheter through a vein or an artery in your leg up inside your heart or your brain to do some work. Things today that seem a little bit science fiction, Black Mirror-y, will become relatively commonplace to a point where there's standard of care, clinical practice guidelines, and expansion beyond that. Is it going to happen in 5 to 10 years? Yes, but what is it? it would be the first products, medical devices that doctors can prescribe to their patients for the disorders that we're discussing, restoration of speech, restoration of motor capabilities, and then expanding beyond that to longer-term, higher functioning devices, expanded maybe surgical technique, minimally invasive, and seeing how other medical therapies innovate within themselves, going from first of its kind to latest and greatest to minimally invasive and eventually cheaper, faster, but just as high performing, if not better.
Thank you, Noah. Bruce?
I see things moving in two directions. I see some colleagues of mine in the audience who are developing advanced methods to basically measure function and connectivity at the mesoscale in the brain. I think we're going to be able to apply these tools effectively to really shorten the exam times, to make these important localizations, and also teach us fundamentals about human communication. I'm also quite bullish and maybe a slightly longer horizon on the non-invasive methods. I would love to see them at least initially applied perhaps in these chronic care settings that you talk about. And ultimately, perhaps in a 10 to 15 year horizon, more ubiquitously in more and more settings to get patients out and about and the ability to communicate regardless of their ability to articulate.
Thank you, Bruce. Danielle?
I think in 5 to 10 years, sort of tougher conversations in the ICU up front, which is not a bad thing.
What's that? Wait.
Personalizing this to those that are up here, I think 5 to 10 years from now, either Danielle in a long-term care facility or me in the ICU, we're going to recognize somebody who might have previously believed to have been either in a coma or in a vegetative state. We're going to wonder whether that's actually true or not. We're going to look to the world expert in disorders of consciousness, who's sitting to my left, and who is going to quickly determine exactly how we're going to figure out whether that person may not indeed be in a vegetative state, but may be in a condition of a cognitive motor disorder or dissociation, or is in some version of a locked-in state, actually is awake and alert and has that cognitive processing that is needed to recover, to be able to communicate again. I'm going to hand over to Bruce, who is very quickly going to help us to figure out where could these devices be placed using the advanced imaging techniques so that we can restore communication mobility, and then handing representationally, of course, over to Noah, who is then going to place, he representing an entire industry here of brain-computer interfaces, that by the end of the week is going to allow that person to say, thank you, what took you so long?
Thank you, Lee, for those.
Brian, no, I was just going to say, Brian, we need to ask you the question.
Yes. Well, I'm mindful of time, and I don't want to get in trouble. I echo Lee's sentiments. Amen. I think we have a bright future ahead of us in which individuals who have covert consciousness will be identified and given a new voice, and we are very close to that reality. It's been an honor to moderate this panel. Thank you for your attention. A big round of applause for our panelists.